Hi everyone, thank you for joining us today and welcome to the latest ViteAccess Keeping It Real webinar. Today's subject is Mapping the Patient Journey, Data Storytelling in Patient-Centric Research. The overall aim of today's webinar is to show you how data can be used to build up a picture of a patient and their health. We'll be using case studies from our experience as a patient-centered research organisation to show you how patient-focused data from various sources can be collected, pulled together, analysed and presented in order to tell a rounded story of a patient's journey. I'm Emma Bagshaw. I'm a senior medical writer here at ViteAccess and I'll be hosting the session today. I'll now introduce you to our speakers. So I'm joined today by Laura Day, Associate Director of Analytics, and Harshitha Ravindra, Data Visualization Lead. Laura is an analytics expert. She's got a background as a medical statistician in clinical research. She provides oversight to the statistical analyses in our studies to ensure meaningful insights can be gained from the data that we gather. And Harshitha is a pro in all things data visualization. She oversees the visual analysis and presentation of data from our studies, so making sure that the results can be understood and interpreted by a range of audiences, both technical and non-technical. So what's in store for today? I'll begin with a brief introduction to ViteAccess. I'll then hand over to Harshitha, who will talk about how we can use real-world data to illustrate a patient's journey. She'll also be discussing the different conclusions that can be drawn with longitudinal versus cross-sectional data, as well as how data from different sources can be linked together to build a more complete picture of a patient and their experiences. We'll then pass things over to Laura, who will take you through the dissemination of results, with a particular focus on sharing data with patients themselves, so how to do so effectively and in a way that can benefit study engagement. Laura will go on to discuss data quality and finish with a discussion about how robust real-world data can be effectively used in regulatory submissions. The main body of the webinar should take about half an hour or so, and then if you have time to stay around after that, we'll have a question and answer session. We've already received a few questions from audience members who replied to our email earlier this week, so thank you very much for those. Please feel free to submit any further questions at any time during the webinar. You should see a question and answer box in the side panel of the webinar window. If we don't get a chance to answer your question today, we'll do our best to reply to all questions via email, and you can always follow up by contacting us directly via email if you've got questions after the event as well. Okay, let's get started with a little bit about us. This will be quick, I promise. So ViteAccess is, as I said, a patient-centric research organisation, and we specialise in real-world primary data collection. We work closely with our clients to design and execute research projects that put patients and their caregivers first. So that might be a cross-sectional survey that asks caregivers about their quality of life, or a long-term study collecting regular data from patients via a smartphone app on their own phone, perhaps about their experiences of living with and managing their conditions. Our key expertise is in these areas you see on screen. So real-world evidence, analytics, HUR and market access, patient-centered outcomes, and localization. And by bringing these functions together, it enables us to design and run global patient-focused studies that generate reliable, relevant data. That's all about us for now. So I will hand you over to our speakers now. Our first speaker is Harshitha, and she will begin our discussion shortly. So Harshitha, over to you. Thank you.
Thank you, Emma. Hi, everyone. I'm Harshitha Ravindra, Data Visualization Lead at ViteAccess, leading the development of dashboards, visualizations, alongside different analysis work and insighting. Today, I'll be talking about the use of real-world data to illustrate patients' journey alongside the case studies with visualization to illustrate some of the scenarios. It is important to discuss the real-world data and the benefits of utilizing it around the patients. Real-world data encompasses information collected from various sources. including patients, health status, and their delivery of the healthcare. By using this data, we can gain a better understanding of patients and their needs, which can lead to improved treatments and outcomes. Real-world data is obtained from different sources, such as the medical history, treatments, surveys, qualitative interviews. So these data is important and critical to understand patient real experience and the context in which they live and operate. So we believe that there's a significant value in leveraging real world data to improve healthcare and outcome. Next slide, please. Thank you. In order to gather comprehensive information, we utilize various resources of data, including ECRF, which is the electronic CRF, mobile apps-based survey data, web-based data, and all of these data collected are securely stored in a database or a data lake for further analysis or any of the visualization or dashboarding. As part of our ongoing study, we gather data from the patients through an mobile app and from clinicians through an ECRF. So this way, we gather both the data and merge these data, which can create a more thorough understanding of the patient experience throughout the study. Next slide, please. This way, we also explore the patient journey in any of the given study, right? So a patient journey in the real world study is a comprehensive research that tracks the experience and the outcome of patient. They receive different medical care. So this typically follows from patient or at the point of diagnosis through treatment and their recovery and assessing their overall health state, quality of life over the period of time. The goal of these studies is to gain insight of patient experience and identify opportunities to improve the healthcare delivery. We collect data on a different range of factors, including patient demographics, medical history, symptoms, diagnosis, treatments, medication, different medication of use, adverse events, and outcomes as well. By gathering this data with the real-world patients in their natural healthcare setting, we can obtain a more accurate picture on how healthcare is delivered and how patients respond to various treatments. We talk about patient journey. So although this slightly varies with respect to what kind of study we do, which is the cross-sectional studies or the longitudinal studies, with respect to cross-sectional study, where data is collected at single point of time, all these data are collected at single point of time. Whereas with the longitudinal study, we collect all these data again over extended period of time. This way we get to understand their quality of life, their treatment history at each period of time. Overall, exploring the patient journey plays an important role in understanding the healthcare delivery and improving patients' outcome. Next slide, please. This is a case study which we present using a visual representation of patients' data. The visual representation here represents the adverse events reported and the stages of melanoma using a core diagram. This is the data from one of our study, which is melanoma study, Melanoma UK app, through an Melanoma UK app, which was being collected, where we wanted to put together both the adverse events reported by the patients and the stages of melanoma which they were currently on, using a core diagram, which shows different adverse events reported by the patient at each stage of melanoma. This kind of interactive visualization helps visualize the relationship between the both of the variables which we have used, which is the adverse events and the stage of melanoma, allowing the clinicians or researchers to identify patterns or trends in adverse events across different stages of melanoma. So this always reflects back to our mission, which says giving patient a voice through technology, isn't it? So we develop all our registries collaboratively with the patients and organizations that help us understand critical things such as how AEs are impactful in their lives and how that can be presented with data that they can use. Next slide, please. This is a infographic where the information was gathered from the patients in our melanoma study, prioritizing the patient-centric data here. This information talks about the patient demographics, their lifestyle, their diagnosis and staging, treatment, surgeries, and hospitalization. For example, if you consider diagnosis and staging information here, those shed light on the types and severity of the melanoma cases included in the study, as well as the BRAF status that helps in diagnosis as well. In terms of the treatment, the infographic gives us an overview of different treatments offered to the melanoma patient, as well as some of the most bothersome side effects reported. We did present this visualized infographic during a conversation with the patient group to emphasize on the significance of information they contribute and its value in various research studies. Next slide, please. This particular case study is regarding a treatment pathway, where the treatment pathways pertains to specific sequence of treatments given to patients with certain conditions. This pathway differ based on factors such as the severity of illness or the type of therapy utilized, medical background of patient, and more. So with the treatment pathways are quite essential to understand or ensure patient receives appropriate treatments and all those healthcare costs as well. So this kind of visualization does help us in achieving those kinds of information to the clinicians or researchers who are trying to understand the pathway as well. So if you could see that in this particular chart, which is a Sankey plot, which shows the first column shows the first line of treatment which the patient received in their medication, and so goes on up to n number of treatment which they have received throughout the journey in the study. Next slide, please. Here in this particular case study, we're talking about the quality of life in patient-reported data and how this data can be used in any of the data storytelling. So the choice of plot could be always based on what is that you want to convey or type of research you're trying to answer, research question you're trying to answer, or based on available data. Here in this particular visualization, wherein you can see on the top visualization, it's a simple box plot where we have used to represent the EQ5D data, which is the activity, anxiety, mobility, pain or discomfort, and self-care. Here we could see that most of the patients in the study did range from no problem to moderate problem, although we did have some of the patients, the participants, in the extreme and severe conditions as well. So this is one type of representation based on what you want to convey to the group which you're trying to tell a story about. And coming to the another visualization, which is in the bottom left, which is called spider or ladder plot. Here in this particular visualization, where we talk about how each of the condition across each group you're talking about can be seen, and this is just a mean representation you see, although you don't see a minimal and maximum. It does differ, as I mentioned, based on what is that you want to convey. So this is also another representation of the similar data. The last one is the bottom right. This is a particular visualization which allows you to compare the quality of life scores across different time points in a clear and precise way. This way, you are able to tell which particular participant or patient had a higher quality of life score or lower quality of life score at what point of time. So these things could be an effect from different factors. It could be different internal factors. Let's say, for example, some treatments which they've started, or there's treatments which are already on, or any other factors which it is affecting, or any of the external factors as well. For example, this data here you can see is somewhere in April, from January to September 2020, which is exactly during the COVID time. So you could say that as the things progressed with COVID, which is an external condition, the quality of life with people, participants, some of the participants did decrease. This is which helps you to correlate and compare between participants and different factors which you want to correlate as well. With that, I think that's all from me. I want to hand it over to Laura.
Thanks, Harshitha.
Thank you, Ma.
Thank you. Hi, everyone. I'm Laura. So we've talked a little bit about conducting patient-centric research, but in order to have patient-centric research, we have to look at patient-centric results from that research as well, because if patients understand how their data are being used, then they're more likely to keep participating in the study and in research as a whole. So on the slide, you can see a few ways that we can do that, and we can disseminate those results to patients. So one of which is data nuggets. So this is what we've termed them. And they are high-level summaries of key pieces of data from the study, sorry. And they're an effective way for patients to see the impact of the data that they're contributing, and also how others with the similar condition or the same condition and what they're experiencing, and they can compare themselves to that. And these data nuggets can be fed back through social media or email, or maybe even through patient advocacy groups or app dashboards. And they can really help patients understand how their data are being used. Another example here is patient-focused webinars. So these can be used to present initial findings from studies, the background of a study, and kind of emphasizing the importance of the study as well, and any progress that's being made. And if the webinar is done with key opinion leaders and clinicians, it also gives the patients an opportunity to interact with those people that they may not usually get a chance to interact with. And another example here is a regular study newsletter, which is maybe a slightly more classic method of disseminating results to patients. And again, that can just be around study progress, study results, any new features. Maybe in a longitudinal study, you'd expect to see more features being added as the study's going along, so you can inform patients that way as well. And the final part I wanted to mention on this slide was the data feedback element. So this could be something like if they've been keeping a diary, an electronic diary, or a tracker of some sort, they can see a summary of their data to take to their clinician, or just for their own information. That is extremely valuable to patients. Next slide, please, Emma. So how can we improve data quality? Because this is quite a hot topic at the moment. And for me, there's these three areas that are really important. So I'm talking here about prospective studies with primary data collection from patients or caregivers. And the first one is user experience. So if it's easy to use, if it's nice to use, then people are more likely to want to use it. It's really that simple. And our focus in the design and development of our studies is patient centricity, as we've said. And to maximize the data that we get collected and the quality of that data, it's really vital that participants can use our apps and enter their data with ease. And that encourages participants to complete all of the data entry that we've asked them to do. And that's for cross-sectional studies, and then to actually come back and keep providing that data in a longitudinal study, is if they've had a good experience, they'll come back and keep providing their data. And if it's difficult or clunky to enter the data, it's demotivating for participants, and they simply won't want to bother entering any more data, or they might rush through or not quite understand and provide some incomplete data. The second one, as I touched on just now, is patient engagement and understanding. So it's also important from the data quality perspective, as patients understanding what their data are being used for and the way that their data can contribute to improving treatment and care for others with the same condition is likely to improve the quality of the data that they provide if they can see tangible benefit to themselves and the community. And if they're engaged in the study and they feel valued and that the data that they're providing is really important, then they are much more likely to contribute meaningful data. And then the last part is the statistical analysis. Again, a bit more classic. It can be used to maintain data quality, and it can be two different ways, really. Empirical or data-driven. So, for example, univariate or multivariate analyses just to detect anomalies or outliers in the data. And then the other would be more clinician or expert-led, where certain patterns or certain combinations of data probably wouldn't make sense. So then we can look at the data, conduct analyses to see if any of those unexpected patterns occur and look at them in conjunction with other patterns that might be occurring within that patient and make a judgment call from there. But it's a whole cross-functional team effort on that one, really. It's not just an analysis problem. And it's also important to mention the existing frameworks for real-world data studies. So, for example, the NICE real-world evidence framework, which includes guidance around data management, data specification, quality assurance, all those kinds of things. And obviously, the key point is the more data we can collect of a high quality, the better we can understand the real-world implications of living with certain conditions for patients and for their caregivers, which is ultimately our main aim. Next slide, please, Emma. So I just want to talk through a couple of case studies now. So this one, the objective of the study was to capture real-world disease management burden and health-related quality of life in individuals living with a rare disease. And the data capture method was participants were asked to complete surveys, which included PRO instruments on their disease, its management and the impact that it was having on their lives, and that was over a 2-year study period. So some of the things that were implemented throughout the study for retention and engagement were there was establishing a scientific advisory board to advise on strategies to adopt during the study. And again, as I mentioned just now, distributing data nuggets, which contained snippets of study data, and they were disseminated via patient associations. And then the three that I wanted to focus on really here were creating this study app profile and tracker pages. And that's what I mentioned just now about participants being able to create their own record of disease management. And this was associated with high completion rates in the study. And then adaptive monitoring. The survey completion schedule was revised during the study to reduce participant load, because feedback was that there was too many surveys. And then finally, implementing rewards. For this particular study, it was in the form of charitable donations, and these were received for completing surveys, and this actually resulted in a 41% increase in survey completion rate from pre-launch. And the benefits to the study are we have got a granular global data set for HTA and publications, and it strengthens sponsor links with patient advocacy groups as well, and with key opinion leaders. Next slide, please, Emma. And then the last case study I just wanted to talk through was, and this was an observational longitudinal study, which was designed to increase understanding of the impact of living with a rare autoimmune neuromuscular disease. During an assessment of treatments for this disease, the Institute for Clinical and Economic Review, ICER, requested evidence on unmet need, caregiver impact, and complexity of current treatment regimens. So what we did for this one is we developed an analysis plan that included analysis of correlations between EQ5D utility scores and the range of variables that could potentially be used to define model health states to demonstrate which would be most appropriate for the economic modelling. We included a comparison of the burden of disease in the target eligible patient population, both for the sponsor's product and the wider disease population. We included an exploration of the relationships between disease severity. This was measured by activities of daily living score and direct and indirect costs. And finally, we included analysis of categories of pharmacological treatments split by disease severity. And the outcomes of this were the study provided data and health-related quality of life, healthcare resource use, caregiver burden, work productivity, and these just simply weren't available from the clinical trials. The analyses comprised data on medication, hospital-based resources, primary care health visits, burden in society, and also targeted analyses based on economic model and health state requirements. And these data analyses provided real-world evidence on key considerations and the optimal approach to economic modelling during HTA review. And that's it from me.
Okay, thank you very much, Laura. Okay, right, we've now reached the question and answer section of today's webinar. We've had quite a few questions come in during the session, so thank you very much for those. I'll just have a look through and see where to start. Okay, I'm going to start with one that should be fairly straightforward to get the ball rolling. So, how do you collect, for example, EQ5D data? So could that be centralized application of the questionnaires by phone or local interviews? Harshitha, I think you were talking about EQ5D. Are you happy to take that?
Yes, I can take that. Yeah, basically we use electronic PROs where we able to collect all the EQ5D data. When we are using a mobile application, we would have surveys associated to that. So that's how the participants would fill in the details for the EQ5D data. If it's with respect to web survey, again, we will have a particular section associated to EQ5D. That's where the participants would fill out all the details for the EQ5D. So yeah, we would have an application web-based or an app-based based on what the study is associated to at that point of time. That's how we collect all the PROs within ePRO state of data collection. I hope I answered that. Yeah.
Yeah, thanks. Laura, would you like to add anything there? Or
no, I think that covers it.
Perfect. Okay, let's see what we've got next. Okay, so how do you facilitate data capture that is at worst neutral and at best even a positive experience? So I guess if I paraphrase that, how do we make being part of our studies a fun experience for patients and participants? That's a very wide question. We could say a lot. Does anyone want to get started?
I'm happy to start. I think it comes back to a little bit about what I was talking about with the user experience, and at the center of it, making sure that the way that we're asking questions and the way that we're asking participants to fill out their data is a good experience for them, and it's easy to use, it's easy to navigate, there's nothing confusing about it, it's an all-round kind of as pleasant as it can be, a pleasant experience. And then of course you can get into the rewards or the gamification in the study, and that actually then comes into tangible rewards for entering that data, whether that's charitable donations, monetary gains to the participant, or if it is simply gamification and collecting stars or something like that. Those are all ways that we can do that.
Thanks, Laura. I think I'd just add, we do when we're putting together the protocols for our studies, we do spend a lot of time trying to find that balance of collecting the right amount of data with not collecting too much, that it's a burden for participants, particularly not collecting too much any one go. So we'll make an estimate of how long surveys are likely to take to complete, and make sure that we don't put too many surveys together in one go. The burden there in terms of time is not too high. So people might only need to do sort of a 5-minute survey once a month, say, and we'll have the option there for them to be able to save surveys and come back to it later if that's appropriate for the type of data that we're collecting there. So just trying to make that as easy as possible. But there's all sorts that we can do to improve participant experience, and a big part of that is speaking to participants through the study design to see what motivates them, what are barriers to participation, and taking that feedback on board when we're putting the studies together. So let's see what else we've got. We've got quite a few questions here. I'll just keep an eye on time. Okay, so there's one about the nature of real world studies. So we've described a lot of our research as real world research, and one questioner is asking, how real world is that if rewards are implemented, there's many feedback loops, you're giving things back to the patients, will this not introduce a certain bias? And if so, how do you account for that? Laura, would you be happy to answer that?
Yeah. I think it comes into we're quite careful with the way that the flow works. So participants wouldn't be rewarded prior to consent. The consent would all be around participation in the study, and there's no benefits to them per se. The rewards just come later as part of, because I mean it's the patient's data and they are providing it to us, so and rewards do work, and we've seen that. So what was the second part of the question, Emma? Was there a second part? So
there was one part about the feedback to the patients, and if that creates a bias, so like feeding back data.
Yeah,
does that influence what data they're then going to put in next?
Yeah, so we do try to think about it, and we do try to be quite careful with what data we use for the data nuggets. It's always at an aggregate level. It's never generally for individual patients. It will be for the cohort as a whole. So in that way, that they can't see their individual responses. Say we summarize DQ5D, it would be what is everybody experiencing overall, and then that shouldn't influence too much how they then go on to answer next time.
Yeah, I think that's a key thing.
Emma?
It's the aggregate data I think makes a big difference, so that people aren't, they're not seeing their individual results, and they're not being able to say, well, last month I said this, so this month I'm going to say that. They've got to not be influenced by that. Okay, this question is a nice compliment. So how do you create such beautiful Sankey diagrams when in practice there are huge variations in patient pathways? Harshitha, are you happy to take that one?
Yes. So again, this sometimes it might be a bit complex to create a Sankey diagram because of how it takes the data sometimes. But it's all depends on what is that you're going to answer with respect to that particular data, right? So with what we have put together, we wanted to we had different treatments or similar treatments taken at different point of time. So that's what we wanted to present, those kinds of visualization using Sankey plots, which had more better insight when looked upon rather than anything else. So that was the main intent of how we put together. So and also we use R to do all the visualization at this point. So we have used R to develop the plots itself. But with respect to storytelling, it's all about how you want to put your data together and what is that you want to convey to the. That's when the variations to the Sankey plots can be put in together, and that's how it tells the different story of how you want to narrate it.
Thank you. Right, let's see. We've got a few questions about sort of data quality. So how do you ensure data integrity through your studies? Usually, sorry, just paraphrasing here. Usually the rigid requirements about data integrity integrity that are necessary in randomized controlled trials are not met in real-world studies. I suppose it depends exactly what they mean by data integrity. I mean,
Yeah.
Laura,
Okay.
are you happy to explore that?
Yeah, I can try. So we typically try to follow CDISC standards where possible. It's allowing for the fact that we are doing real world studies, and it's not always feasible to collect data in that way. But the way we store it, the way we manage it, the way that we do the data cleaning all follows a similar process to how it would work in clinical trials. And in terms of some studies, we would use site-based recruitment. So we would get some of the characteristics, the clinical characteristics entered by the clinician, which perhaps many people would see that as more reliable or more accurate. So then we can put that together with the patient data and create a fuller picture. But we've got that kind of grounding and basis off what the clinicians have said. And yeah, I think it really does just come back to the data management processes and the cleaning of the data, and trying to kind of follow the real the clinical trials guidelines, but making them work for real world studies.
Yeah, there's got to be an appreciation that it is different from a clinical trial. And like just picking up on the point you said there, Laura, about using data from clinicians as well. We are seeing more and more studies where we're combining those two different types of data and they're complementing each other. They're not meant to be exactly the same. We're getting data from patients, and that might be more about their quality of life, their symptoms, how they feel, their burden. And then you've got perhaps the more clinical data being collected from their health records. And it's I suppose what we've been saying a lot today is combining those two things. It's what you need to build up the full picture of what's going on, isn't it?
Absolutely.
Okay. I think we've got time for a few more questions. If we don't get a chance to answer them all today, there's a few that might require a bit more of a longer explanation, so we'll try and get back to people via email if we don't. Okay. How do we ensure that patients who aren't motivated in their care or they're not familiar with digital technologies are fully represented in our samples? So the questioner is thinking perhaps about people who have mental health difficulties or elderly patients. I mean, it is worth acknowledging to start off, there are groups who potentially can't participate in our kinds of research as easily. Like we do a lot of our research digitally, and that does place some limitations, but I don't think they're as bad as you expect. I mean, we've done a lot of investigating about the types of people who do take part, looking at the demographics, and particularly with the age-related one there, we find that we do get a high proportion of people who are, say, in the over 65 group. Laura, you'll know more about this. Could you explain a bit more, please?
Yeah, I don't have the numbers off the top of my head, but I know that we do have a lot of over 65 participants, and some of our studies the majority are slightly older adults, and we've not had any feedback to say that they've struggled. But what I would say as well is that depending on the disease area and the likely age of that group of people, perhaps we work with patient advocacy groups, we talk to patients, we get feedback on the parts that they might find more tricky, and we work together with them to try to make it as easy as possible. That's not to say that there's not some people that just won't be able to participate, as Emma said, or will find it very difficult to participate. And I know that there's a lot of research being done out there at the moment about like digital health divide, all those kinds of things, which it's not necessarily in scope of this webinar, but it is a much wider issue. I think it's trying to get every group participating in research and feeling able to participate in research.
Yeah, like Laura said, we do a lot of speaking to patients and advocates to work out what the barriers are and how to overcome them, right from like the start point when we're thinking about how to identify and recruit patients. Well, where are the patients that we're interested in going to be spending time? Where are they going to hear about it? Are they going to be looking online in a patient advocacy Facebook group, or are they going to be actually picking up a physical leaflet in a clinic, depending on who they are? Right from that point through to getting into the study, using the apps, making the apps easy to navigate with clear language that's accessible to as many people as possible, localizing into different languages for people who don't speak English. There's a whole host of things we can do to make life easy for participants and remove some of those barriers. And actually on that point, if you are interested, our most recent webinar about how to design a study app for a patient-centric real-world study does have a lot of information about sort of accessibility considerations that we implement in our data collection tools. So if you are more interested in that topic, I'd recommend having a look at our most recent webinar, which is available on our website. Going back to just one other thing on that question, talking about people with mental health problems, or perhaps people who aren't fully capable of providing data on their own behalf. We have done studies where we've collected data from caregivers as proxies for patients, so we can collect very patient-centric data still by speaking to caregivers rather than directly to patients. So that's an alternative for certain patient groups. It's all about looking at the needs of the particular population and trying to make the study work for them. There's a lot of flexibility in what we do. Okay, let's see if we've got time for one or two more. Okay, so there's a couple here about sort of sharing study results and how we do that. So I'll try and merge them together. Basically, how do we decide how to present the results for different audiences? So for clinicians or for patients, do we present things in different ways? Do we speak to those groups about what they'd like to see in the presentations and the visualizations? How do we decide what's appropriate for different audiences? Would anyone like to take that one?
I can take it.
Thanks.
I think, I'm just thinking, a lot of it is kind of just a classic way of reporting, like to the wider research community. We would do the kind of classical end of study report and publications off the back of that, abstracts, posters, manuscripts. But when it comes to disseminating the results to patients, we have discussed with patient advocacy groups in the past about how they like to see the data, what the data nuggets mean to them, what the webinars meant to them, what they got from those things and those interactions with the clinicians in the webinars. So some of that was from the patient, the feedback from the patients. The clinician part I'm less familiar with. I don't know if Emma, Harshitha, you have anything to add?
Not particularly. I suppose when we're speaking in our advisory boards, it is often a mixture of clinicians and patients, so we can seek feedback from clinicians there as well. But I suppose for the clinicians, it is a bit more straightforward. You would typically go down the traditional route of conference presentations and publications. Yeah, I think that's all I'd add for now. Okay, let's see if we've got time for just one more. We've had quite a few here, so just want to pick to finish on. Okay, Laura, you might have covered this one to a certain extent already. We say that we use real-world evidence for regulatory submissions, or that you can. Do we fulfill FDA requirements for full data transfer? That might be getting a bit too technical, but I'm not sure if you're able to answer that one.
I think the answer is that we can. We have done it to lesser and greater extents, probably still not to the full extent. We have the capability because of the way that we set up our data sets, when we collect the data, when we export the data from the cloud storage service, and then how we set up our analysis data sets and all of the documentation that goes alongside that. So we are set up to do it. It's not necessarily always required for the real world data part of submissions. But if it is required, if we're submitting to the FDA or any other body that needs it in that format and that needs the full kind of complement, if you like, we can do that, and we are set up to do that. I think that's kind of all I would say on that, really.
Thanks. Okay, let's see if we've got time to cover one more. This is quite a broad one, so we might not get time to cover it in any great detail, in which case we'll reply by email. So what are the panelists' thoughts on how the NHS can harness the power of real-world data? It's broad, so sorry about that. Such as using its routinely collected NHS data sets or audit data. And what, if any, are the capability gaps in doing so?
Yeah, so I think there's plenty of scope for doing it, but the way that the NHS is set up at the moment, and the fact that different trusts collect data, they store data in different ways, the linkage is tricky in the background. I mean, it's not my area of expertise, but from what I do know and from what I understand, it is tricky. But initiatives like the Darwin EU initiative, things like that, and I know that recently NHS Digital and NHS England have merged, so things like that are going to hopefully lead to linkage being easier later down the line. But at the moment, I think the main barrier is the fact that the data are all just a little bit different, so difficult to link together. And yeah, different data is recorded by different trusts. They record stuff in different way. And
so it's a
collect
big mess,
different
is what you're
data.
saying.
Yeah, it's. Yeah, I think there's really great data in there to be utilized, but at the moment, getting a hold of it and putting it all together is the biggest problem to me. But again, I would caveat that with it's not necessarily mine or our area of expertise.
Yeah, I think most of the studies that we've worked in the NHS are slightly different. We're sort of asking specific clinicians to provide data about specific patients with that patient's consent, whereas I think this is more along the lines of using potentially anonymized data from large groups of patients across the NHS, which, like you say, it's very powerful, and I do think they're starting to try and do that more, particularly with COVID. I think that drove a lot of change in terms of linking things up and getting the system to work better as a whole, but it needs time and money to get things to work properly. I suspect that's going to be the biggest constraint. But there is so much you can do there, and in terms of like you can improve health of individual patients by being able to predict what's going to happen by looking at large scale trends, but you can also look at like from a public health perspective, improving the health of the nation by being able to look at such a vast amount of data in one go. So there is huge benefit if there is the time and money to be put into it. So right, we're at 10:02 now, so I think we'll probably finish up with the Q&A there, if that's all right. Yeah, as I said before, if anyone has any further questions, please feel free to get in touch. You can find our contact details on the final slide. Thank you everyone for taking the time to join us today, and thank you again to our speakers, to Laura and Harshitha. We hope you enjoyed today's webinar, and we'd love to see you at our next one. So this is our little plug for that. It's going to be about how to navigate ethics requirements in patient-centered real-world studies. Look out for information from us about how to register for that, or you can head to the Right Access website where there'll be details there. And as I mentioned before, if you'd like to catch up on any of our previous webinars, you can also find those on our website.